Is it regular or irregular? Looks very regular to me. And it is regular, let me tell you. Okay? So, do we see P waves? And it's, I mean, how fast is it? It's about 300, it's about 150. So it's fast. We can't really see P waves. It's regular. So the first thing you can call it is, it's a tachycardia of some sort. Tachy, it's fast. And it's a so-called supraventricular tachycardia. What type? We don't know yet. We've got to do something to slow down the patient or get them out of it. Okay. So what we did, we put the patient on rate slowing medication, beta blocker, cortisone, something like that. Okay. And when he came back to the office, this is what we had. So is it fast? Is it slow now? It's much slower. It's the same patient as before. Okay. Now the heart rate looks quite nicely. It's 300, 1500. It's about 75. Okay. Do we see P waves? You think so? Okay. Do you think there's more P waves than QRSs though? Yeah. So if you have more P waves than QRSs, and those P waves sort of look regular, what do you think it is? That's flutter. Exactly. That's the hallmark of flutter. Okay. You have lots of P waves. Okay. And this particular example, you actually have three flutter waves, 3 P flutter waves to every QRS. And like in this lead, this and here, your T wave doesn't really look like a T wave. Usually the T wave, like it is here, is bigger than everything else. But in flutter, sometimes you don't, the P wave and T wave almost looks the same. Okay? So you can see how there's 3 little blips to every QRS, 3 little blips to every QRS. Okay? So that's flutter. So here's another example. So what is this? This was a stress test. The patient at first had some AFib on the treadmill. We stopped, let the patient sit down, and all of a sudden he does this. Heart rate is about 160, 169, it says up there. And the patient does, I don't remember if he felt it. He just clocks away to 160, 170 beats a minute. And so there's some things we can do. Now, in the clinic, we could maybe try medications. In the hospital, we can. But there's some things you can do faster. Have you guys had ACLS? Any of you? Or just CPR? Okay. Well, in ACLS, Advanced Cardiac Life Support, there are maneuvers that you learn, medications that you will learn that are used to get people out of this. Okay? Because they can be unstable with this kind of arrhythmia. So it looks fast, right? Anybody agree with that it looks fast? Everybody agree that it's regular? Okay. So that, but it doesn't look normal. Do we see P waves? When a heart rate is that fast, you usually don't see P waves. Okay. So I'm not exactly sure, but this has to come from above the ventricle because our QRS is nice and narrow. It's like almost one up and down line. You'll see in a bit when we have ventricular rhythms, the QRS becomes really broad and wide. So a narrow, complex tachycardia, which is what this is. Okay, but we don't exactly know what's underneath. So we can try several things. As cardiologists, cardiologists, we can try carotid sinus massage. And we can try to have the patient cough or bear down as if they, try and push out a BM. Or we can give adenosine to try and get them out of this. So what we did with this patient, we gave him adenosine. And if it's a straight SVT, supraventricular tachycardia, which is what this looks like, something else, it won't break it, but the adenosine can help you see what it is. So this is what happened. So this is a rhythm strip. This is not an actual EKG. You see this looks the same as over here, okay? So we're giving the adenosine, and what happens? What is that? It's flutter, exactly. So adenosine will slow down the heart, but it will not break flutter, okay? But it is usually emergency room in that same fashion to try and sort out what something may be. If it breaks them, fine, then you know what it was. If it doesn't, at least it slows you down enough to see that it's flutter. And then you don't know what else to do. Okay? Now, right after this next EKG, the patient went right back into that. And I don't remember what we had to do to get him out of it. It's been a few years ago. Okay? So here you don't see the P waves, but it's way too fast. Okay, it's 170 beats a minute. And then once we slow it down, we slow down the ventricle, but we're not affecting the atrium at all, so we see all those sawtooth P waves. Okay? So that's what adenosine does. It's a very fast-acting medicine. And you see how quickly it slows the patient down from 170 to what? 30? If you've ever had to give adenosine or watched them giving adenosine, or you'll do it for yourself down the road, at least warn the patient, because they can feel like their heart's going to stop on it. Okay? That's not a comfortable feeling. I mean, going 170 beats a minute may not be comfortable, but going from that to almost zero is very scary. So you need to warn your patient that when I give this medicine, you may feel like your heart's going to slow way down, and may feel like you're going to stop, but it's going to be okay. All right? So, talk a little bit more about SVT. The P stands for paroxysmal, comes on sudden, goes away suddenly. Okay? And patients will say, oh my God, it just like started, literally just like that. And it can stop just like that. All right? And you have that narrow QRS. Okay? Unless you have a bundle branch block. You'll see that in the bundle branch blocks. Because anything happening below the AV node, your QRS starts widening. Okay? So you know it's not happening in the atrium. Okay? And there's three main types. We already talked about AFib flutter. Okay? WPW, we're not going to talk about. It's a very specific pattern. So what you mostly see, and what you sort of saw in the previous EKG, is this. It's happening in the AV node, and it sort of has a classic pattern look to it. And that's it. Okay? Now they can be very fast. I've seen it recently. This gentleman was going close to 250 beats a minute. Okay? And he felt it. So this is what SVT looks like. It's very fast. It's regular as clockwork. It's like, ooh, okay, like a jackhammer. Okay? You will not see P waves because it's going way too fast. This cannot be anything else. You wouldn't just call this, oh, tachycardia. If the heart rate is a 110, 120, yeah, you can call it tachycardia. This is what we call SVT. This needs to be treated. You can't leave the patient this for very long. All right. Now, because the heart goes so fast, it has a hard time filling itself. It has a hard time filling the coronary arteries. And so you can see things, which we'll talk about in a bit. You see where the ST segment is this right here? See that little flat line right there? That's your ST segment right there as well. That should be up there next to the P wave. It should be in our imaginary line, and it's pulled down. That's called ST depression. But in SVT, when the patient has this kind of rhythm, it doesn't mean they're having a blockage. It's because the heart goes so fast that it can't fill itself properly. You actually get a so-called ischemic pattern on the EKG. When they come out of this rhythm, the EKG may be perfectly